Start again. Assalamu alaikum and a warm welcome to everyone joining this evening. I'm Shehla, BIMA National Director for Advocacy, and I'll be chairing this discussion with the BMA on solidarity and responsibility, how unions can make a difference. And this webinar has generated a lot of interest and is part of a three-part webinar series regarding advocacy, how to navigate complaints and disciplinaries as a mean of possible censoring of legitimate political opinion in light of the genocide we've been bearing witness to. So without further ado, I'm going to ask my fellow panelists from the BMA to introduce themselves and then we can make a start on the session. So we'll start off with Latifa and then if you can hand it over to one of your colleagues.
You can't hear me. I kept myself on mute. Sorry.
That's
My
okay.
name, someone's got to start off that way. It'll be me. My name's Latifa. I am a chief officer at the BMA, chair of the representative body. So I chair the annual representative meeting, which is the main policy forming meeting of the BMA. I'm also a respiratory pediatric resident doctor based in the northwest of England. Really nice to be here. Thanks.
Great. Thank you so much for joining us. Aishnine.
Hi everyone, my name is Aishnine Benjamin and I'm the head of the Equality, Inclusion and Culture team, which is a policy team in the BMA.
Great. Natalie.
Good evening. My name is Natalie Fitzpatrick, head of local recruitment and organisation, and my department focuses on member engagement, and we meet with doctors and students in hospitals and medical schools, and we help members support each other with running campaigns and providing reps with campaign materials and resources they need.
Perfect, thank you so much. And Jim.
Hi everyone, Jim Stringer. I'm the head of the BMA Midlands Region and I'm covering for Shazia Kareem, who is my opposite number in Yorkshire and North East, part of member relations team alongside Natalie.
Perfect, thank you so much. So the session outline will provide some context, a bit of background as to how we've got to this point today. I'll hand over to the BMA to do a presentation regarding some of the issues we expect that will be addressed during the course of this webinar. And then I'll run through a case review, which is anonymised, just to really see how that fits in with what the BMA can offer if any of our attendees today or other colleagues may face similar issues. And we will aim to have as much of a Q&A just to allow that interaction with our attendees today with members or colleagues from the BMA. So if you do have any questions whilst the webinar is running, then please do use the Q&A function. In terms of the context, there's been a significant increase in GMC and disciplinary referrals, which we're all aware of. And the November 2023 BIMA survey highlighted significant levels of censoring, self-censoring, vexatious referrals, an upsurge in Islamophobia and targeting of colleagues for speaking up about the atrocities that we've witnessed. And BIMA undertook work with our stakeholders to really understand what was going on with respect to the disproportionate referral rates and the outcomes. And this meeting has really come about after a recognition of BIMA members and non-members from BIMA seeking out our support clinic for pastoral and legal support, which we would normally expect to be facilitated by the BMA as a union for doctors. And this webinar is to provide a space for respectful conversation and challenge regarding our membership's experience, and we hope that will be taken in that light. I am now going to hand it over to the BMA to do their presentation, and then we'll move on to the case study. Thank you. I'll hand over to you, Aishnine.
Thanks. Just going to try and bring up the presentation.
Thank you very much. We're going to do a COVID Chris Whitty style where I say next slide, please, for Aishnine. And thank you, Aishnine, for taking control of those slides. If there is any crying during this presentation, it's not me. My children are both asleep and are on monitors next to me. So I can't apologise for them, obviously, but I apologise for any noise you might hear. The next few bits I'm going to rattle through because actually the main body, the interesting bit of the presentation is what my colleagues Natalie, Jim, and Aishnine will be covering. But I think it is probably pertinent to mention I'm the first ethnic minority woman chief officer of the BMA. The BMA is almost 200 years old, so it's a long time coming, and it's needed, and it's been important. I'm also the first Muslim in this role, first person to have a baby in this role, not once but twice. And the first resident doctor to be in this role. I'm not the only one. So after me, Emma Runswick is also a woman. She's also Northern, which I think is also pertinent, and is a resident doctor. So we've set off a theme, and I think that's really important. If there's any colleagues out there in BIMA who would like to become active in the BMA, I'm happy to give out my email address, and I would really encourage you to do so. I'm also the equality lead within the organisation. We have key areas of the organisation that we all work on. Equality is one of those amongst others. And my main ambition over the course of the last 4 years since I've been in this role have been really to represent those who are minoritized, not necessarily the minority. We know there are more women doctors than men doctors in the UK at the moment, but we are still minoritized as a group, and to make the BMA more accessible and inclusive. Next slide, please, Aishnine. You'll know that the BMA is both a professional body and a trade union. That is pertinent, that is important. It's a bit of a balance and a weighing scale into which area we concentrate on more. At the moment, and certainly since 2022, the BMA has concentrated more of its funds and its resources towards the trade union side. For a long time prior to that, it was probably more of a professional association, but they both work in harmony together. We cannot do one without doing the other, and we need advocacy on both parts for our members. Next slide, please. What do we do for our members? We give employment advice and support, career support development, organising and taking collective action, and using our collective voice for change. It's really important to know we're a member organisation. We're almost 200,000 strong, and we do essentially what our members tell us to do. And I think the next slide will cover that. Next slide, please. So as I said, I chair the main policy forming event of the BMA. Each year we have, it's actually around about 560 to 660 members, elected members from across the UK, from across the different branches of practice, from across seniority, all the way from medical students through to retired members and everyone in between. And we come in a room together and we debate motions that were submitted in April are debated in June. They are prioritised by an elected agenda committee, and we come to a decision together. Now, you spoke about respectful discussion at the start, and that's what we try to foster at ARM, respectful discussions. And the policy made at ARM shapes the future of the BMA for the 12 months that are coming, but also in the future. My role, of all the 4 chief officers, the other chief officers we have are Phil Banfield, Chair of Council, Emma Runswick, Deputy Chair of Council, Trevor Pickerskill, who's Treasurer. My role is quite unique in that my personal views I'm not allowed to speak of. Well, I am, but I don't, because my views become that of which is policy. So I'm sort of the gatekeeper of policy, and whatever the policy is directs me in what statements I make and how I represent others. And if you sort of look at the statements I've made in the past 4 years, you'll, I hope, recognise that, especially in the role I've done as equality lead. Next slide, please. And I'm handing over now, aren't I?
Jim.
Yeah.
Thank you very much.
So I'm just going to do a brief overview of member relations, our structures in England. I'll touch on the nations as well. So this is a map of the 7 operational regions in England for the BMA. We mirror now in our operational structure the NHSE regions, and what we're showing on that slide is the currently 42 integrated care systems. I say currently because the government's just announced that they're going to reduce those care systems to around 23 to 27. So for instance, in the Midlands, the green band in the middle will go from 11 integrated care systems to around 5 or 6. In Scotland, Wales and Northern Ireland, they have slightly different structure, but health boards. But the important thing is that every member, where they work or where they live, is linked to one of those regions and sub-regions across the UK for their support. Next one, please, Aishnine. So in terms of the representation we give via that structure, what we provide is both individual and collective support in employment situations. Alongside that, and I think other slides touch on this, we also provide counselling and career advice. But we'll go through the way that we triage and provide that advice on the next slide. But just to underline that, as well as individual reps at our first point of contact, which you approach via a web form. There's actually a hyperlink on the slide for that, but we can send that to Shehla in due course. Each NHS trust is underpinned by a local negotiation committee. That's a collection of our local representatives from every branch of practice, resident doctors, SAS doctors and consultants, who negotiate locally with support from BMA industrial relations officers on the terms and conditions at that local trust. What we're increasingly trying to do is pick up collective trends in casework. So we're not just looking at your case as an individual case. We're looking at have other members got those issues within the same trust or area, and can we therefore take that up as an issue both with your employer or, if necessary, with the integrated care system. And that's particularly important on the equality front. And next slide, please, Aishnine. And this is very briefly the route from when you complete and submit a web form. It goes to our first point of contact. They will triage the complaint for urgency and also for whether they can actually resolve the case, if you like, at the front door. So some queries are relatively straightforward. They're about contracts, etc. And our FPC team are trained to deliver that initial advice directly to you. Sometimes it will be just initial advice on what you should do next before you come back to us. If, however, it's a more difficult case, then it's triaged and prioritised to one of the area teams as per the map we just showed, or the three nations, if it's a Scotland, Wales and Northern Ireland case. And it'll be referred to a local advisor, depending on the nature of the case. That will be an employment advisor, or if it's a more serious case, it will go to a senior employment advisor. If we've picked up already that it's a collective case, and it's quite helpful if you do approaches, if you know that other colleagues in your area have got the same sort of issue, if you do flag that on your web form or in your first conversation, because then it will also be allocated to someone like me as an industrial relations officer to take up the collective side. What the local advisor will do is to make contact with you, talk through the issues, support you through the case, discuss how we take the case forward, and then we agree a course of action with you and support you in whatever the issue is, whether it's you raising a complaint or grievance within the trust, or whether you're the subject of a complaint or grievance. Depends on how we handle it, but either way we'll support you in that process. And I think Aishnine, that's my three. Yeah.
So I just wanted to touch on the professional association side that Latifa mentioned earlier. Most of our work is based on BMA policy that sets our work. We do lobbying of different organisations externally, such as government, NHS, other bodies. We don't talk about it necessarily, so it's influencing behind the scenes, but it is based on our policy. We do research and guidance, and we do lots of external stakeholder engagement. Just a few examples of those things you might have seen. We have many different teams. So our ethics team produce social media, ethics and professionalism guidance. We've produced how to manage discrimination from patients guidance, and other pieces of work like that. Some research that we've done, racism in medicine survey, which I'm not going to go through, but I did want to highlight that was in 2022. It was a survey, but it also had some qualitative points. And I think it's just interesting, this quote, because that was in 2022. Things have changed since then, but they haven't really, because this was a quote we had through that survey that said, as a visibly Muslim woman wearing a headscarf, I was targeted by having a complaint made about me for politely raising concerns regarding patient confidentiality during prevent training. Several white doctors made similar comments and had no action was taken against them. I was too frightened and concerned about my career progression to take things further, particularly in the current virulently Islamophobic climate. I never imagined something like this could happen to me I no longer feel safe at work, cannot trust my colleagues, and would leave medicine, the NHS completely if I had an alternative employment. So I just wanted to highlight that because that was something we found in 2022. That type of feedback helps give us evidence to the work that we do. And it's, I think, just a bit sad that that was then, and things probably haven't changed that much now, if not got worse. We also do statements, and that was after Israel-Palestine conflict, to show support for doctors, and just give a kind of clear line as to what was acceptable and what wasn't, and how the union, well, professional association as well, would be supporting doctors. And at the moment, we are looking at some guidance, which is quite difficult, but at the moment, the guidance is balancing free speech and professionalism in healthcare guidance. It is quite complex, and we'll talk about that a bit later, but I wanted to say just the starting principle for this guidance. The starting principle is that doctors and medical students should be free to hold their views and beliefs and express them fairly. Where you go from there changes depending on the context, but that's always the starting principle. Okay, I'm just going to hand over to Natalie now.
Thank you, Aishnine. As Latifa explained earlier, the BMA is a trade union, and the role of a trade union is to protect and further the interests of its members. And we do this by negotiating with the government and employers over doctors' working conditions and pay. We're not an indemnity insurer. Indemnity insurance provides cover for clinical errors and patient complaints. The BMA is here for employment-related issues. Next slide, please. Last year we supported over 20% of our members with problems at work, and we helped resolve over 50,000 issues for doctors working in hospitals. We also manage queries and member casework for doctors working in general practice and also medical students. Next slide, please. While you're working, you want to make sure you're being paid correctly. You may have rota issues that mean you're working too many hours. You may be being treated unfairly in the workplace. You might have questions about your annual leave, study leave, or sick pay. And we have advisors that work closely with every NHS trust. So wherever you're working, we can support you. Next slide, please. Over recent years, more doctors from overseas have been registering with the GMC than those qualifying here in the UK. And we're seeing lots more international medical graduates report issues that are unique to doctors from overseas. And we provide advice to doctors and medical students working and studying in the UK while on a visa. Next slide, please. As well as your trade union, the BMA is a professional association, and membership includes access to world-class learning resources through the BMJ. You also get access to BMJ Learning with thousands of e-learning modules, which are very quick and easy to complete, and you get a certificate to evidence your learning. BMA webinars, again, you receive a certificate of participation. BMA Library offers a range of online services. And finally, Clinical Key is a powerful search engine for doctors. You can access step-by-step procedural videos, help with drug information, unit conversions. I spoke to a GP recently who told me his access to Clinical Key and the BMJ resources more than justifies the cost of his BMA subscription. Next slide, please. And we provide information on a wide range of pension matters to individual members of the NHS pension scheme, examples of why members might contact us to ensure benefits have been calculated correctly, to help restore missing or incorrectly recorded service, ill health retirement appeals, to discuss redundancy options. And individual financial advice is offered by our new partner, Fidelius Medical. They are experts in doctors' finances, and they can create plans to get you where you want to be. They also help with mortgages, savings and investments, legacy planning. And BMA Law is a fully independent law firm providing the full range of legal services. So if you need a will or conveyancing, they can help. Next slide, please. These are exceptional times for the NHS and the health service. We have a wellbeing and counselling service. Over 4,000 doctors contacted the service last year. If you call the service, you get the choice of speaking to a counsellor or a doctor for peer-to-peer support. And there's always someone you can talk to. Next slide, please. And the Doctors Support Service provides confidential emotional support for doctors. Support is provided by the BMA, commissioned by the GMC. For more details about the service, please visit the BMA Doctors Support Service on the BMA website. Next slide, please. And BMA Lifestyle Discounts offers members a fantastic way to save money on everyday purchases and special treats. And members get preferential rates on various retailers, so they can enjoy significant savings. And there's a price promise guarantee. If you find a better deal elsewhere, you can get the difference back. Next slide, please. And there's many ways that members can get involved with the BMA. The BMA is only as strong as the people that make it up, and that's all of us. When members are more involved, we're more powerful at the bargaining table and we're more visible in the workplace. You don't need to be a rep to make a difference. Just being engaged already puts power in our hands. And there's loads of ways that you can get involved with the BMA. Even small things can make a big difference. Chatting to colleagues about the BMA, helping spread campaign messages, or joining local WhatsApp groups. And staff are here to support you, whether you want to help out occasionally or take on a bigger role. Next slide, please. If you're interested in the 3 pathways, then please apply through these QR codes. A member of staff will be in touch. We will be sharing this presentation at the end of this evening, so you don't need to do this now. Next slide, please. And membership costs between £10.50 and £44 a month. It's tax deductible up to 40% back. You may also be eligible for a concession if you're new to the UK, if you're on mat leave, if you're working part-time or you're currently not working. If you have any questions about concessions or joining membership, please email me nfitzpatrick@bma.org.uk. I'd love to hear from you. And if you want to join the BMA today and receive your first month free, please follow the QR code here on the presentation slide, and that will take you to the online joining form. And that's all from me. Thank you for listening to me.
Hello, you're on mute.
I've done it myself. So thank you so much to the BMA team. What we wanted to do as part of this evening's webinar is really go through a case that came to BIMA through our support clinic and really understand where the BMA could have or can offer support for somebody who feels they are having a similar allegation put to them. So in this situation, it's a consultant colleague who was working in the NHS at the time and was notified by the GMC that a complaint had been submitted to them regarding posts that had been put on social media that was felt to be anti-Semitic hate speech using the IHRA definition. So the doctor was notified by the GMC in April 2024, and subsequently the GMC began a formal investigation process. This doctor contacted BIMA Support Clinic in May of 2024, where we provided pastoral care and wellbeing support whilst this process was being navigated. In August 2024, there was preliminary findings from the GMC that concluded its initial inquiry, and the case was referred for potential misconduct hearing prior to October 2024, when the doctor responded acknowledging authorship of his posts, but denied anti-Semitic intent, citing political expression and Article 10 of the ECHR. In 2024, December of 2024, the GMC eventually closed the case. It found no explicit anti-Semitic content and no further action was taken. And what we've done, as I said in the context of today's webinar, is really go back to the BMA and say, actually, during this process, where could the BMA have come in and what would you have done in addition to what BIMA is doing? And is there any dissonance between, people coming to BIMA either based through race, ethnicity, or more likely faith, compared to the BMA, which obviously is the official union? Don't know if Latifa, if you want to run through that, or anybody else from the team in regards to where BMA could have offered some support to this colleague, or any other colleague who faces anything similar in terms of the allegations.
I wonder if Jim or Natalie want to come in terms of how they could have got in contact with member relations.
Yes,
services.
if I start, so obviously there are quite a few routes to the GMC in terms of a complaint. The last stats I've seen, about 2/3 of complaints come from the public. And I think from the outline we've had, Shehla, that was the case here, a group of the public. A much smaller amount, around 4 to 5%, come from employers, and then about 40% come from CQC, the police, etc. So in this case, there's no, at this stage, direct employment link. So I think where we would come in general terms is, as I think Aishnine's clearly hinted at, or not more than hinted at, social media is a minefield for us now. So we do collective presentations to trusts about the use of social media. That's become particularly important given that the 2024 version of Good Medical Practice refocuses on social media as a factor that we're looking at in terms of doctors undertaking good medical practice. So that would be our collective start. What we find is whether it's initiated by the employer or the GMC potentially raise the issue with the employer, or indeed neither of those things happen, but there is a sanction against the doctor, then there's undoubtedly some impact at employment level. And that's where we would normally look to support. In terms of a GMC referral in isolation that hasn't come from the employer, generally the BMA doesn't support it during GMC proceedings. We would obviously, as we put in the presentation, give similar pastoral care, I think, to your organisation, BIMA. But what we'd be looking for really is an early contact to see if there was any, if you like, knock-on effect to the doctor's employment in terms of the GMC action. Some trusts are, what should we say, very risk averse. So as soon as they were notified by the GMC that this case was going on, they might seek to take action locally. Others would sit and wait to see what the GMC did. In this case, thankfully, there was no action. I think my concern, as undoubtedly is BIMA's concern, is that we are seeing increasing number of these cases. I've had one myself where a consultant, for all the right reasons, I think, repeated a tweet about the terrible situation in Gaza and was immediately called up by the trust themselves and had an internal process against them. For me, I think, building on what Aishnine said about, we clearly support the freedom of expression. We have got an extra dimension for doctors and indeed medical students in relation to the GMC that, you know, I could potentially tweet something, and although the BMA might be unhappy about what I've tweeted, I haven't got a registration for my job, so I don't have to worry about a register. For doctors, of course, that's the extra dimension we have to take account of, and that's why we certainly try and do collective presentations at trusts and more widely to try and underline to doctors that you have to be very careful what you do on social media. Of course, it's understandable that given the terrible situation and unacceptable situation in Palestine, feelings run high, but you've got to find a way through that, which it sounds like in this case the doctor did do. Their repost or their original post wasn't anti-Semitic. I've no doubt we could debate all night what does and doesn't constitute anti-Semitic behaviour, because I think that's another minefield that frustrates me as a non-Muslim, let alone for our Muslim colleagues. One other area that I just mentioned, Shehla, which I think might help is in terms of collective work, where we've had terrible issues like the Stockport killings that have been used by some elements of the press to particularly pick on our Muslim colleagues, both doctors and indeed staff. We've been able to take action locally to ensure that support for doctors who were literally scared to go to work. So that's a long answer to a relatively straightforward question. In terms of GMC proceedings, I'm afraid we don't operate, but we can do a lot of work around the sides to support you both in this sort of area and more widely.
Thank you. And I think the impact on doctors in terms of potential loss of job, career, and so on is significant. And, you know, the impact of censoring and self-censoring that goes on only compounds that. So thank you for sharing the BMA view on that. I'm conscious of...
Sorry, Shehla.
Yeah, of course.
Can I just add a couple of points to sort of add to what Jim has said? In order to get BMA support, I know this should be obvious, but you have to be a BMA member, and you have to be a member at the time of the incident. So retrospectively joining isn't good enough. Natalie made it really clear that there are some service benefits even going to one conference alone, in terms of reimbursements, travel, accommodation, etc., you'll get your money back. So I would encourage members to join the BMA. You have to let us know early. It is no point once it gets to GMC. If it's an employment issue and you let the BMA know, and colleagues like Jim and Natalie can support you, it might never get to the GMC. If you let us know when it's at the GMC, it's kind of a bit difficult to get involved there. And that's where your medical defence organisations get in. Really, those are just the points I really wanted to take home. Thanks.
Great, thank you so much, Latifa. We'll move on to Q&A, which obviously, as panelists, we can see the questions pouring in. So let's make a start on that. So how does the BMA plan to protect doctors who express pro-Palestinian sentiment going forward, both within the BMA itself and the workplace, particularly in view of what we've already talked about, vexatious referrals, impact on ongoing, career opportunities, career progression, particularly for working with a trust, obviously accepting that working in general practice is slightly different to that. What would you answer to that? Oh, you're on mute, Latifa.
So I can come in on that. And sorry, I did get distracted when Jim was speaking in terms of looking through the questions.
Mm-hmm.
So this is where the professional aspect and the trade union aspect comes together. And I'll talk about inside the BMA and outside the BMA. Inside the BMA is dictated by policy. And you'll see some of the statements, and we have made a lot of statements on the conflict because it is important since 2023. If you type in BMA health medicine and the conflict in Israel, Gaza and the West Bank, you will see a list of letters that we've written to the government, a list of statements we've made and other letters to the NHS, etc. In terms of within the BMA works to its policy, and I hope I don't have to say this, we don't have pro-war policy. We only have pro-peace policy. We only have pro-ceasefire policy. We only have policy that tells us to abide by international humanitarian law and to abide by the Geneva Convention. We apply that across the globe on all conflicts. So that's what we call for. We don't get involved in all conflicts, but we get involved in conflicts, particularly where health professionals, doctors are involved. And certainly in Gaza, we know healthcare workers and doctors are involved. There are concerns within the BMA from some BMA members, elected members, about the language used. And inside the BMA, certainly we have a resolution process. So anyone who's elected or anyone who's a BMA member who has a concern goes through that. That is independent and external to the BMA. Outside of the BMA, we've kind of already talked through that in answering the case study. If you have a concern, the BMA is geared up and is ready to support you. Unfortunately, the problem we have, and BIMA can support here, Shehla, we've had many conversations about this, is we're not trusted. It's not only Muslims and ethnic minority colleagues that don't trust the BMA so much, and I understand why we're not trusted. Historically, the BMA hasn't been the voice of brown people. It hasn't been the voice of ethnic minorities for too long. In over the last 200 years, the leadership within the BMA has been predominantly men and predominantly white. But that is changing, and all I'd encourage BIMA members and colleagues to do is test the BMA. And if we fail you once you come to us, then that's another matter. I hope that's helped slightly.
Thank you. And I think just following that, there's somebody else who's put in that many colleagues expressing advocacy for our colleagues in Gaza have not felt supported by the BMA when they have had a false accusation of anti-Semitism against them, usually mediated by UK LFI. So the question is, who's directing the BMA and why is there a fear to openly advocate for members expressing pro-Palestine views? And I think that ties in also around the question regarding transparency and openness, as well as accountability, with the cancelling of Dr Sui Ang, who was supposed to be talking at a conference, and whether there's an external political pressure being applied to the BMA with respect to member representation or free speech principles.
Okay, so there's a lot of layers to that question. I know this is not what BMA members at home are going to want to hear. Aishnine, Jim, and Natalie, if you want to come in, feel free. On the case of Dr. Ang, I'm not going to comment, and I hope that's okay. And that's also for the confidentiality of Dr. Ang. That we're having ongoing conversations. But I know that's not what you want to hear, but I'm going to say that, and I hope that's respected. It's not in my gift to comment on that. And by doing so, I'd be doing it an injustice. Nobody is directing the BMA except for its members, and I truly mean that. On behalf of the chief officers, I lead on international work. It just so happens that the RB chair role is that I sit on the World Medical Association Council. I attend their meetings. We are the only national medical association who took a resolution to the WMA out of 50 plus NMAs across the globe. I can direct you to, and Shehla, if it's okay, I'm going to share a load of links if you want to pass them
absolutely.
on.
Yes.
I can direct you to some of the statements and the ongoing work that we have done since October 2023. The difficulty lies in the fact that not all our members want us to comment. Some of our members don't believe we should have a professional association side at all. They don't believe we should do any international work, any human rights or medical ethics work. I believe we should do both. I believe it's as important to be a trade union as it is a professional association, and vice versa. And the question then lies, how do we appease everybody? How do we represent over 200,000 members? And we will always get criticism from one corner and the other. UK LFI, and I have to say this on record, and I appreciate I'm going live stream, they do not dictators. They have made some allegations before, they have made some statements before. I know prior to ARM, and I've never said this on record, and I don't mind saying it now, after ARM 2024, they published a letter where they said that they basically dictated what happened at ARM 2020. That's not true. It's just a false statement. The truth of the fact is that so many false statements are made by the BMA that we don't spend all of our time correcting them. And I'm sorry, I appreciate for BIMA members, that's not a nice thing to read that and believe it's true because it's not been corrected by the BMA. But resources are finite, time is finite. And I'm sorry, but I'm not going to make it a priority to call out the UKLFI, but making a false statement every time they make a false statement. So, I mean, take from that what you wish. All I would say is at this point, you need to get involved in the BMA. Get involved, submit motions, get involved in the policy making structures, get involved as an elected member, and you could be doing the work yourselves.
And I think you've touched on this already, Latifa, with regards to ARM last year, and there was a sense of direction and lack of transparency as to how motions were being put to the membership. Have you made any adjustments to that process to provide that transparency as well as accountability to make sure that the local motions that are being put forward by members who feel very strongly in this situation are having them put through to the national platform so that those motions can be put to the entire membership rather than being suppressed at a local stage?
So last year's ARM, in terms of what was published in the Prioritised Agenda Part 1 and Part 2, was the most transparent ARM we've ever had in our history. And I'll say that again, that was the most transparent ARM we've ever had. We normally get between 400 and 500 motions. 10% of those are prioritised. The other 90% are left into a section called Part 2, previously called Grey, and they are not reached unless pulled out and chosen by RB. There's no reason for them. You have no idea as a member why your motion was not prioritised. Last year, for the first time, and this was an incentive I took based on feedback, we gave every motion a code. And that was how people knew how and why they were prioritised or deprioritised. This is not the first time motions have been deprioritised of a certain group, purely because ARM Agenda Committee felt it wasn't the right time to debate. And I'm not talking about Gaza, I'm talking about general motions. We've had motions in the past on areas which we thought this isn't ours to debate. And it hasn't been debated for whatever reason. And that's down to the Agenda Committee. They are elected, they are accountable. If you do not feel they represent you, get involved, stand for their positions and vote for someone else. It was coming off the back of that. And I also wrote a letter that explained how we prioritise, that we received feedback from a number of members. Off the back of that feedback, remember the decision the Agenda Committee makes is never final. It's not final up until the point of ARM, and I pride ourselves on that, in that ARM is flexible. We made a number of changes, and I appreciate for many members at home, BIMA members specifically, this won't be enough, but more of our ARM agenda concentrated on the Middle East conflict, on what's happening in Gaza than any other topic. There were 4 motions that concentrated in Gaza from a total of about 32 motions. That is a very high percentage, and I appreciate it's not enough, but for an organisation representing 200,000 members, who is both a trade union and a professional association, that's actually quite good numbers, and I'm saying that from an objective manner, or trying to be objective.
Okay, thank you so much. So in terms of there's another question.
Sorry, Jim wants to come in.
Oh,
sorry,
yes, go ahead, Jim. Sorry, I missed your hand up.
Just to reassure people on the call, if they are BMA members, there is absolutely categorically no filter at a local level on cases. We look at every case on its merit. As I say, I've dealt with a case in my own area where we were able to get the consultant off with a very low level warning for retweeting what was deemed to be an anti-Semitic tweet. There's a massive debate about that, as I'm sure you're aware as an audience. My personal view is you should be able to criticise the Israeli state without being deemed anti-Semitic, but the current climate is such that that's much more complicated than that simple statement. But if you had any head of region here or head of nation, they will categorically assure you that we do not deny support to cases. We look at every case on its merits, and we would advise the member based on the nature of their individual case. So there's no filter at our level at all on those sort of cases.
Thank you. And I think this is probably, Aishnine.
And I just wanted to say, from a professional association point of view, the policy is so important to us because it gives us the kind of remit and gives us the strength to be able to do the work that we do. And that's why representation is so important, because it makes it it's harder if there's no policy. We just can't. Our hands are tied.
Thank you. And again, we're getting a lot of questions about ARM. So what has the BMA done to safeguard doctors who speak up for Palestine within the organisation? For example, what has happened in the case of the Jewish doctor who was heckled at last year's ARM? How are we to know that we will be safe from similar bullying at this year's meeting or at other BMA forums? Similarly, why was Mary McCarthy investigated? Does the BMA realise that simply by agreeing to investigate someone, it has a chilling effect on what people say and do?
I mean, I can answer that. In terms of discussing the case of the incident at ARM, I can't, and I genuinely can't, because it's still undergoing investigation. It's external, it's independent, it's completely confidential. It's not my story to tell, but it was taken incredibly seriously, and it still is. Similarly about Mary McCarthy, that is also a confidential case, and the only reason you might have heard of both cases is because it's been spilled into the media. That's where we're at. People who speak out for pro-Palestine, there is no speaking out for pro-Palestine, pro-Israel favoritism in the BMA. There is simply the humanitarian cause and speaking out against injustices against the international humanitarian law and Geneva Convention, which we do have a concern about. And you can read that in many of the statements that we have published since October 2023. Again, I appreciate BIMA members will want us to say more and will not be happy with my answer, but please respect that I physically can't say anymore, and I am sorry about that.
No, I understand, obviously, to protect, particular individual cases, there has to be an element of confidentiality there. Yep.
Sorry, Shehla, can I add, as a direct response of what happened at ARM last year, I am actively looking at having independent facilitators, whereby if there is an incident, elected members will be asked to leave the room. We didn't have that in place last year. I couldn't be confident who the hecklers were, and I could not, for that reason, ask them to be removed. And once I did find out, they were already into the complaints process.
Okay, thank you. I'm just conscious of time for people who need to pray Maghrib. This webinar is being recorded, so it will be made available for those people who need to take a few minutes out to do their Maghrib Salah. But we'll carry on. So moving away from ARM, I think Aishnine touched on this in her presentation in regards to racism survey and that particularly horrific instance of Islamophobia that one of our Muslim female colleagues brought up. And we know as a society, as we're moving geopolitically, but also more nationalistic in political opinion, that there is a rise in Islamophobia, both in the NHS, medical institutions, and also more widely. So how can we, as a community of doctors, have confidence in the BMA representing us when people that are part of or endorsed by the BMA, such as Simon Minkoff, openly express racist remarks? So I appreciate you're not going to comment on somebody individually, but if you have, members of an organisation such as yourself openly expressing racist remarks, how does that engender confidence and faith in the BMA that you'll be represented and have the Islamophobia addressed?
So the BMA does have zero tolerance for discrimination. I cannot voice this enough. We genuinely do, and we are doing a great amount of work. And I, lean out to people like Jim, Natalie, and specifically Aishnine, who is doing a great deal of work looking specifically at discrimination. Under this leadership team at the BMA and working with the staff and elected members, we are actively doing more on discrimination than I think we've ever done in our history. Aishnine, I don't know if you think that's an overstatement, but we are seeking it out. I noticed I have been scanning the question, and there was a comment about colonialism. There's no denial of that. The BMA and most of the medical structures across the UK are built on colonialism. Absolutely. One of the first things I did mid-term when I stepped up was apologise for the racism, the sexism, the colonialism, and the homophobia we've expressed as the BMA, as a body of doctors. And once we admit it, only then can we work towards rectifying it. What I will say is, if you are a member and you have evidence of another member discriminating, particularly an elected role who is representing you, then you need to let the BMA know. There's a confidential line. You put in a complaint. I appreciate putting a complaint is very, very difficult. I myself have faced lots of discriminations, and it's really hard to sit down and put a complaint through. But unless you let the BMA know, nothing can happen. And again, I won't mention the case that you've already mentioned because I can't, because there is a confidential complaints process that I am not able to comment on. Aishnine?
Aishnine, yep.
So I just wanted to say that last year, September, we published an anti-discrimination statement. And at the time, being a quality university professional, I was a bit worried about this because I'm like, a statement, what's that going to do? But it was based on anti-racism principles. And within anti-racism principles, they have the concept that we seek out discrimination. We don't sit back and assume that we haven't got it. And that means that the BMA has to be humble and accept that it's changing organisation, that there is discrimination, that it's something that we're looking for. So the approach that we've got at the moment is getting everyone to change their mindsets, to think, where can we find it? And we want to find it, we're not going to bury it. But that takes time. But that's the kind of thing that we're selling now internally and getting people to get their heads around, is how do we seek out, how do we get to that place where an organisation that's constantly seeking and learning on this.
Thank you. So I think that's obviously quite a lot around where obviously Islamophobia, anti-discrimination and the historical discriminatory practices that are, entrenched in all levels of society, including healthcare. So we can't expect it to not be affected by similar issues. Just moving away slightly from what we've already talked about, somebody's asked a question. My IRO is often unavailable and not contactable. Who can you contact if you find the BMA support to be subpar?
So I would say if you go to the head of region on that slide, I think the contact details are on there for each head of region. So if you can't get hold of your IRO, I normally get people to escalate it to me, and then I try and find out what's going on. IRO is obviously very busy people. But we should be able to find someone else who can support you if they're not available.
Okay, thank you.
Can I add to that? There's also a complaints process. You can make complaints about anybody. You can make complaints about me if you wanted. You type in BMA complaints and you'll get an email. And also Jim touched on this, but if, for instance, you're a woman and you want a woman representing you because the issue is sexism, which we know is rife in the BMA, rife in the NHS slip there, but and worse for intersectionals, those who are ethnic minority, if you want to speak to a woman, you can make that request and that request will be respected.
Thank you.
Sorry, I've checked. The emails aren't on the slide, but our protocol is first initial, surname @bma.org.uk, but all the names are on the slide. Okay,
thank you. So there is a lot of pressure in the BMA to focus on majority issues. So obviously the resident doctors strike and, a recent notification regarding what's going to happen there with the DDRB statement, and then there's obviously pay pensions. But although those are what can be deemed majority issues, they're not always the key issues that matter to doctors. And you've already mentioned, the importance of motions and ARM. There is a question regarding what steps the BMA is taking to ensure that the policies and professional conduct are not weaponised against certain political or ethnic groups, particularly if they're Arab, Muslim, or anti-Zionist members. So how do you balance out trying to understand the needs of very particularly marginalised communities, such as our members who feel they can't speak up because of the censoring, the self-censoring, versus what's going on externally with regards to political pressure and so on?
Can I clarify that question? Sorry, do you
Yeah,
mean
sure.
that our policy might
Yeah.
be skewed because of who's submitting it? I mean, that is a very, very fair question, genuinely very fair, and it's something I've mulled over and thought about. What I can say is, as an agenda committee and someone who's been chairing that role, where there are minority issues, and you can look through this yourself. All our agendas are archived. We do go out of our way where it's submitted to prioritize that motion. So if we look on, some of the work we've done on trans colleagues, trans patients, and trans doctors, particularly in the current climate, if we look for colleagues from ethnic minority backgrounds who faced racism, I think racism has been on the agenda every single year I've chaired: 2021, 2022, 2023, 2024. And I can't say about 2025 because we haven't published the agenda. And I do get asked by a number of members, why do we keep talking about racism? Because it's still an issue. Why do we keep talking about sexism? Because it's still an issue. All I can say is you have to test the system. So I understand why you might not want to submit a motion. I appreciate that some people have found it difficult to submit motions. You have to keep trying. You have to get elected. You have to become active. And then once you're in the roles, you need to test ARM. But I can say, evidently, honestly, minoritized groups are prioritized. One other thing that I will say, under my leadership, with the support of the wider ARM team, both staff and elected members, we actively collect equality data. I've been doing that for 2 years now, and I use that equality data to positively discriminate. So in the past, we would profile people. I'd see your name, Shehla. I'd see, oh, Shehla's put in a speaker slip. I think that's a woman, and I think she's ethnic minority, and I want to hear an ethnic minority voice. Now you fill in your detail, and I actively say, I want to see an ethnic minority. You could put it in a comment, I am Muslim and I've got a scarf on, and I will prioritize you to speak first, because I know if you speak first, more women will put their hands up, more Muslims will put their hands up, and more ethnic minorities. And it's not just our categories here, it's categories from people who have LGBTQ backgrounds, people who have disabilities. We go even further now. If you are dyslexic and you let me know you're dyslexic, I will give you extra time. And the only two people know that I've given you extra time on the podium are you and me, because I'll give it you in secret, and I'll just sort of say you've got 15 extra seconds. There is more we can do. I'm happy to take soundings on how we can represent minoritized groups better. Let me know. Thanks.
Thank you. I'm just aware of time, and we're about to approach the time to wrap up. What is the best way to get to ARM? I mean, that's clearly... Oh, sorry, Aishnine, I just noticed your hand up.
Oh, it's just a couple of points in terms of representation. Please do, if you are a member, fill out your diversity details, because that helps us understand the makeup of our membership and where there are gaps, and the voices of our members. But also, I just want to touch on engagement with organisations like BIMA, because the BMA hasn't been representative, and you do have a unique voice. So when we talk to you and you tell us things, we take that on board as evidence and information as well.
Thank you. And sorry, what was the best way to get to ARM for those people who are thinking about? So, I mean, from everything that we're hearing, it's a grassroots change that needs to happen, with people becoming more involved with the democratic processes at the BMA to influence change. So, what's the best way to get to ARM, and how can our members build up that grassroots force to be able to do that?
Yeah, so those seats are divided into two. Some of those seats are accessible through branch of practice conferences. So for instance, if you are a consultant, you go to the consultants conference, you apply through there for an ARM seat. The other route is divisions. You attend your local divisional meeting, or you put your name in to the hat online for ARM representative body elections, and those come out. When they did come out, I did an all-member email. I did several all-member emails this year to remind people and their online elections. I have spotted, I don't normally do this, Shehla, but I realise there are so many questions, and I have spotted two that I would like to answer. Is that okay?
Yeah, of course. Yeah, absolutely. Yeah.
What's the BMA done on other human rights issues? Uyghur Muslims. Again, we are the only national medical association in the World Medical Association Council that took this issue to WMA in 2021, 2022, 2023. We had it passed with the majority, and we called for the expulsion of the Chinese Medical Association. And we have a statement of the resolution that was passed, which is online and available. In terms of other medical ethics and human rights work, we do a lot across the globe. What I would encourage you to do is go into Google. I endorse other search engines, but Google's the easiest. Type in BMA medical ethics and human rights work, and you'll get a whole host of all the work we've done. Shehla, I'll send you a link to spread on. I've also seen a comment that I have just avoided all the difficult questions. The only difficult questions I have avoided are those with confidential panels in place at the moment investigating. As you can expect, if there was a GMC case that was live and I was a member of the GMC Council or GMC FTP, I would not be able to comment. I hope you'd agree that the only comments I've not been able to make are of live investigations that are entirely confidential. I have not made comments on why Dr. Ang was asked not to speak, because it is not within my gift. That is between Dr. Ang and BMA colleagues who made that decision, not myself and the legal team. And I hope that can be respected too.
Thank you. And you mentioned obviously asking for the expulsion of the Chinese Medical Association. There's two questions that came in quick succession. Has the BMA called for the expulsion of Israeli Medical Association?
No. In order to do any work with any national medical association, we need to do background work. We need to think about all the different factors. We are working with multiple organizations across the globe to look into the case of what's happening in the Middle East. And we are working with the World Medical Association on that. As I say, we're the only NMA that took that resolution to the WMA Council meeting. What I will say at the moment, it is very difficult in terms of when there is a live crisis going on to know all the facts. If anybody has details and has more information, you are very, very welcome to email me. My email address is rbchair@bma.org.uk. It's a public email address. If there is more work you'd like me to do personally, you're more than welcome to email me. I hope that's not avoiding the question, that is simply stating a fact. To take any action, as you will appreciate, at World Medical Association level, you need evidence and facts. If anyone wants to supply me with them, you are more than welcome to.
Okay, so thank you for your openness in terms of providing your contact details so people can get in touch with you. I think there's answers generated a few more follow-up questions, and we are approaching the end of this evening's webinar. I just wanted to say thank you to Latifa, Aishnine, Jim and Natalie for coming along this evening. I think you were obviously anticipating some tough questions, particularly in regards to concerns that our members have had, and I hope you can understand the strength of feeling, particularly when we're seeing such distressing images and the kind of moral feelings that evokes in so many people in regards to the disparity that we're seeing with doctors being targeted, but also being asked to ignore what we're seeing and hearing. In terms of BIMA, for those people who are not a BIMA member, please do consider being part of our membership, but also for those people who have asked in the Q&A regarding the support service, we do provide legal support. We also provide pastoral support for well-being for those people experiencing any discrimination within the workforce, not necessarily just regarding the Gaza situation, but Islamophobia or any other form of discrimination. So please do reach out to us. And any closing final comments from anybody, please feel free to speak, and then we can wrap it up for today.
I mean, I can say I hope you've appreciated that I have been honest and candid. You won't like what I've said, and that's okay with me. My role, as I say, is dictated by policy. Your role, as if you are active BMA members, is to make that policy. If you want to direct the BMA, you can shout at me all you like. And I'll leave you with an anecdote. I am a Muslim. Some of your colleagues who I've met don't realize that. I have been consecutively called anti-Semitic and Islamophobic in consecutive meetings. I am a mum. I have had 2 children whilst in this role, and my babies have been in all my meetings with me, and they've been subjected to that. I do this role because I genuinely care about colleagues and doctors. And I had a choice, actually, when I stepped into this role, to quit and say, no, thank you. And genuinely, the only reason I am doing this role is because I know if I do it as a Muslim woman, as an ethnic minority resident doctor, and as a new parent, someone else will see that role and say, if she can do it, I can. So you might not like what I've said, you might not like what the BMA is doing, and that is absolutely fine. But if you want to see change, instead of sitting behind and criticizing the people that are doing it, get involved and do not take that as a criticism of what you're doing. I know some incredible work is coming out of BIMA. And Shehla, I have nothing but admiration. Having been to your conference, I also know a lot of the work is being done by women like you, ethnic minority Muslim women in the BMA, in BIMA. But for BMA to get there, I can only encourage you to get involved. If you feel BMA does not represent you, get online now. You can drop me an email, rbchair@bma.org.uk. I recognize some of the names submitting the Q&As. I will personally direct you on how you can get elected. And then maybe you can be in this position. It only took me 9 years. 9 years from the moment that I stepped in as a BMA member to an elected role to becoming RB chair or deputy RB chair. If I can do it, you can do it. Probably do it in 4.5.
Thank you so much, Latifa. I think you are aspirational and a positive role model. And thank you for your kind words about me, but absolutely a team effort for everything that goes on at BIMA. Thank you for coming, being open and answering the questions with such grace and also humility. I know it's not the easiest coming and possibly facing a lion's den, but I hope that our members will have some insight into the challenges of navigating investigations, but also how to utilise BIMA, but also BMA to influence change both locally, nationally, and hopefully internationally. And I'm now going to draw things to a close. Thank you so much, Aishnine, Jim, Latifa, and Natalie, for joining us. My colleagues Naomi and Brother Shahan in the background, who have been running the tech. And we look forward to everybody hopefully attending next week's webinar, where Nadeem Crow will be providing a follow-up regarding last week's webinar and the outcome of his tribunal. Thank you.